Hello, you are listening to 1 in 2, a Manchester Cancer Research podcast, brought to you by the University of Manchester and the Manchester Cancer Research Centre. With 1 in 2 of us receiving a cancer diagnosis at some point in our lifetime, it has never been more important for our research to improve the outcomes for people affected by cancer. I am your host, Sally Best, and throughout this series I will be speaking with Manchester cancer researchers about their innovations, discoveries and projects that are changing the landscape of early detection. In this episode, we speak to Professor Katherine Payne about health economics, what it is, its importance in cancer treatment, in early detection strategies, and the crucial role it plays in changing healthcare policy. We discuss Katherine's work evaluating the health and economic benefits of banning sunbeds in England and the effect that a policy intervention would have in reducing the burden of skin cancer on the NHS. Hi Katherine, thank you for joining me today. How are you doing?
No problem. Good, thank you.
I'm just wondering if you'd be able to introduce yourself for us and what it is that you do in your job.
Absolutely. So my name's Katherine and I am a Professor of Health Economics based at the University of Manchester. And I work with a number of health economists in my centre, and I also have the role as lead for the Manchester Centre for Health Economics.
So I think I'd like to start off this episode by asking, firstly, what made you interested in health economics?
Yeah, interesting. I've had an interesting route into health economics. Most health economists came into the topic having done degrees in economics. I was part of a family who'd never been to university, so I didn't really have any parents to sort of find out what it's like being at university. So I relied very heavily on careers advice. And so when I was 12, a long time ago, I went to this talk by a pharmacist, and they were... for me, at the age of 12, they seemed ancient. I'm sure they weren't actually that old, but they seemed really old. And I was just amazed about how still vibrant they were and excited about their career as a pharmacist. And I thought, being honest, I'm really squeamish. So I thought there's no way I could be a medic because I would be a medic on the floor. So I thought, right, that's what I'm going to do. I'm going to be a pharmacist. So that's what I set my sights on, and that's what I ended up doing. So I qualified as a pharmacist and started work in the Queen Elizabeth Hospital in Birmingham. And after about 2 years, I thought, do you know what? I can't do this for the rest of my life. I really cannot. So I started thinking about, well, what else could I do? And I started being interested in research and thinking, so I'd done research projects as part of my undergraduate degree, and I trained and done some clinical pharmacy training as well on top of my degree. And so I thought, yeah, I like this research thing. Didn't really know what it was. And at the same time, I was put into a new post for the haematology directorate. And back then we were starting to use some really expensive medicines. So intravenous immunoglobulins were one of the ones that I still remember. And my job was to try and stop people using them inappropriately. I had no real training on this, and so ended up being called the penny pincher on the wards. And that really hurt because obviously I wanted to be a pharmacist and trained my whole life. And they started to think all I was about is sort of saving cash. So then, aligned with this idea that I wanted to do some research, I applied for this fellowship that the Department of Health had set up to move pharmacists into academic careers. And as part of that, I ended up talking to people. It was in the 1990s. We didn't have, the power of the internet. It was the phone. And so I ended up talking to my line manager and another health economist who was really famous called Martin Buxton. And he really inspired me. And I got some money to do a master's. I'd applied for a PhD, was not successful in the PhD, but they said, do a master's. And I thought, well, great, but what in? So that is literally how I ended up being a health economist, because talked to Martin Buxton. He said, do this course at the University of York, and that is what I did. And I thought I would go back and be a pharmacist afterwards, but I went and did this master's. No way could I go back to working on the wards after doing that, because it completely changed my thinking. It moved me away from thinking about individual patients that you're trying to care for on a day-to-day basis to thinking about people being part of a larger population and how we get the best out of things for that larger population. So, yeah, quite a long-winded story, but that's how I ended up becoming a health economist.
No, it's really interesting. I love listening to the kind of chance interactions that have meant people have ended up where they have ended up and not ended up where they thought they were going to end up. And that's the way that it works. But I think just that change of insight and the change of perspective is so interesting. And I'd definitely like to come on to that later on. I'm just wondering if you'd be able to explain more about what health economics is.
I will try. Health economics is a discipline. And so it is massive. A lot of people, I suppose, now think about health economics in the context of the National Institute for Health and Care Excellence. So NICE is the decision-making body that gets on the front of the Daily Mail because they've said no to a particular medicine, and basically all hell breaks loose. So NICE uses something called cost effectiveness analysis, which allows you to think about the impact on the NHS budget, but also capture the benefits to patients in terms of the effectiveness of treatments for patients. But health economics is a sub-discipline of economics, and economics is a behavioural science. So it's interested in behaviour at the population, but also at the individual level. And it's there to produce information so that people can make good decisions about how to use scarce or finite resources. So one example of a finite resource is the healthcare budget. So because health economics is a behavioural science, it means it can work at the macro level, so at the sort of policy level, or at the micro level, which is where we get into evaluation type methods that we're used to seeing used by NICE. But other things that health economists can do is we're interested in defining core concepts. For example, what is health and what is healthcare, and how might we measure health, for example. We're also interested in supply and demand. So how do we best supply healthcare to meet the demand for the services? And we're also interested in using methods to understand what people think about healthcare. So this might be preference type work. So I could talk forever about what is health economics, but the main thing we should remember is this core concept called opportunity cost. And what that tells us is if we spend some money on one thing, then we're not spending money on something else for another portion of the population. So there's a cost for investment in that one particular item, be it a medicine for breast cancer or a hip replacement. So what this does is encourage us to think at the population level about if we spend money on one group of the population, what are the potential benefits to that population, and what benefits are we maybe missing from someone else in the population that isn't immediately in front of us. So I don't know whether that was clear.
No, great. Absolutely great. I mean, I understand. And I'm not in the realm of health economics at all. So, very, very vast but interesting overview. And I'm wondering, with this understanding, why health economics is relevant to cancer research, because I guess that's kind of why people are listening to this podcast and why it's of interest to them. So, I'm just wondering about that cancer research hook of health economics.
Yeah, and I think, again, going back to thinking about the work of NICE, if you look at the number of and type of medicines that NICE appraises as part of their technology appraisal programs, I think the majority are medicines for cancer. And so again, everybody might think, well, health economics then is just all about saying whether or not patients can have this new cancer medicine. And indeed, there is a use for that. You know, it has a vital role in understanding whether a new medicine coming online is worth how much the NHS would have to pay for it, and worth in the sense that patients given this medicine, how much benefit they would get from it and what harms this medicine might cause. But also, if we think about cancer research, at Manchester, we've got an interest in early detection and prevention. And so you can think about using health economics there to say, is it worth investing in this new early detection mechanism? Is it worth investing in prevention programs or screening programs? And the behavioural side is interesting as well, because we can think about looking at interventions to reduce obesity in a population, and economics has a role there as well. And as you know, obesity is an important factor in causing cancer. So there are many different areas where it's relevant to cancer research, but not only in terms of evaluation of new cancer-related interventions. It's also important to think about people's behaviour and an uptake of cancer interventions, such as screening programmes. And that's where a lot of the preference work that we do in Manchester is important, because we can try and start to predict if we design a new cancer screening programme, such as the lung health check, for example, we could start to say, if we designed it in this way, what type of people might use it and what might the uptake might be, because you need good uptake for these programmes to be effective and realise the benefits that they promise.
Great. Yeah, I'd like to touch on some of those points in a bit. But I'm just wondering why the health economic side of cancer research for you. Was that something that you just happened upon? Was it kind of a project that you were placed on?
Yeah, I could be trite and say, well, it's the funding, isn't it? Because you can only do the work you want to do if someone's prepared to pay you for it. But no, I think drawing back on my career as a hospital pharmacist, so I used to spend hours in aseptic suites drawing up medicines, chemotherapy. Used to be very labour intensive, very hot as well. You think we're hot now? We're very hot when you're in one of those, and also seeing people with cancer on the wards. As I said, I work for a haematology directorate, so a lot of blood cancers, and so that's always been there. And there's always been this belief that medicines, although I was a pharmacist, so medicines were always important to me, but medicines weren't always the only solution. And particularly now when they're getting so expensive, and yes, offering people some gain in health, but not massive, teeny tiny amounts. And so starting to think, is it worth it? Is it worth putting a person through this medicine that might give them harms, might be toxic as well? Yes, there might be benefits, and everyone as an individual is right to try a medicine, but I see my role as giving the evidence to people to say, well, if you do invest in this medicine, this is really what you're going to get out of it compared with other alternative treatment options available to people. So there's that pharmacy link, but then there's the stronger link about trying to prevent cancer. And I think that is highly relevant. And I see there's a role for health economics in there.
Yeah, definitely. I think prevention is a massive thing, especially in Manchester. And leading on, I'm just wondering what specific studies you focused on that are kind of related to cancer research that you've done here.
It's really drawing on my memory here. So I don't know whether it's a good or a bad thing. I've now been at Manchester for 27 years. So 2 years ago, I got my 25 years. prize
Congrats.
for being. Thanks very much. Yeah, it wasn't very big, but anyway.
Noted.
So yeah, I'm trying to think of some more recent ones. So I worked on with a colleague called Cheryl Jones. We worked on a project evaluating the cancer vanguards that were rolled out. There's a couple of examples of new services that were rolled out across Greater Manchester. And we looked at trying to understand what the cost implications of rolling out these services might be. I've worked with Stuart Wright on a project where we looked at moving beyond cost effectiveness to think about the impact of implementation of mutation testing for targeting treatments for lung cancer. So there's specific types of treatments for lung cancer that need the tumour to have a particular genetic makeup. And so that requires having a test, the patient having a test involving the tumour sample to see if they're going to respond to a particular medicine or not. And whilst NICE had said, roll out these new medicines, what they'd not thought about is how the NHS could cope with the rollout of the required genetic testing to support that. So what Stuart did is look at what factors might influence the ability for the NHS to deliver these genetic testings for treatments for lung cancer, how that affects the cost effectiveness of the service, and what might be done to try and improve it. So going forward, you could start to predict if a new genetic test came out, how to better roll it out across the NHS. I think you've spoken to Gareth Evans as well as part of this series, and I've worked with Gareth on evaluating his risk-based breast screening programs as well, so looking at the economic impact of that, and also worked on a project looking at quite a sensitive area. We're thinking about removing sunbeds from the high street, and so thinking about the impact of saying to people at a younger age, using a sunbed frequently is perhaps not a good thing. So that perhaps is the most recent project that I've worked on.
Yeah, and I think that's what I'd like to pick up on. I've worked with you previously on just developing blogs for this, and I think it's an interesting area because, number one, there's the prong of UV exposure in being linked to melanomas and other types of skin cancers. And it's that kind of, okay, if you're banning sunbeds, you're therefore saving lives. And then I think there's the interesting kind of part of the model that you looked into, which was more on the health economic side of things. And I mean, I've got some of the articles in front of me, actually, so I'll link these for people that are interested. I know you're not a massive fan of the press, so we can, just kind of breeze over them. The Sun has actually written about it, quite ironic.
Yes.
Dying for a tan, urgent calls to ban sunbeds to save thousands of lives. And then specifically, I'd kind of like to talk about the BBC and Guardian ones, which are... ban on sunbeds could save lives from skin cancer. That's the BBC. And then the Guardian is ban on sunbeds in England would save hundreds of lives from skin cancer, study finds. And I mean, this focuses on the life-saving side of things. But I mean, the BBC states, so researchers applied the same model, so the one that we'll kind of go on to talk about, in England, suggesting it could save the NHS £700,000. So I'm just wondering about that kind of health economic side of things. And if you'd be able to discuss, first of all, how you and your team formed to set up this model. And then I'd kind of like to go on to other aspects.
Okay. So this was one of this sort of cold calls, if you like, from an email from Adele Green. Adele is an epidemiologist based in Australia, but she's also got a position linked with the Manchester Cancer Research Centre. And Adele had been successful in being awarded some money from the Research Town Hall seed grant. And as part of that, she wanted to look at perhaps making a case for removing sunbeds from the high street. This would be building on work that she'd done with her colleague Louisa Gordon, based in Australia. And so she wanted to look at this from the Greater Manchester angle, but also from sort of a wider English angle as well. I have to be honest, when she approached me, I was quite cautious because it's, people's decisions to use sunbeds or not, that's their own decision. It's an individual level decision. And who am I to say, you shouldn't be doing that? But as I said at the beginning of this conversation that we're just having, I'm not really that interested in what happens at the individual level. I'm interested what happens to populations of people, and presenting the evidence in a way that's clear and transparent, and say, right, if you do this, this is what will happen. And so that is why I was perhaps minded to work with Adele and Paul Lorigan on this project. And so I had to find a team of health economists that were willing to work with me. So Martin Eden and Rob Hainsworth both worked with me on this. They're based in the Manchester Centre for Health Economics. And Louisa was heavily involved as well because of obviously her previous work in Australia. So we set out to look at building a mathematical model that would tell you what would happen if you looked at a starting group of people aged 18 years of age, so obviously we've got a defined population of people, and saying, right, if we follow them through their lives, what happens if they have exposure to sunbeds, and what happens if they don't have exposure to sunbeds? And this is using sort of published data to inform the input numbers into this mathematical model. Now, as part to do that, we're also aware of, it's not a case of just banning sunbeds. That's not a sensible thing to do. You need to support that with some public health campaign. So something like we've heard of Movember and Stoptober, things like that. And so we would say, right, let's see how much we could invest in a public health campaign paid for by the NHS, and at the same time remove sunbeds from the high street for 18-year-olds. So that's what we did. So as part of that, we had to try and understand what the relevant population size of 18-year-olds is in England. And so we can use Office for National Statistics data on that. And that's where we come up with our about 620,000 18-year-olds were living in England in 2019, which was our year of focus. And then we also had to try and estimate how many sunbed premises are out there and how many sunbed units are out there. That was really hard. There actually are no published records of how many sunbed premises are out there and units. And I find that myself actually quite interesting because you'd think these premises should be at least monitored in some way. So at least we know how many there are. So we did some estimates based on a really basic method of looking around Google, basically, to estimate how many premises were in a particular area and then rolling that out to an England-wide estimate. So that would be my first recommendation, that if nothing else happens, can we at least know how many sunbed premises are out there? That was sort of, lesson 101 from this. And then we moved on to try and think about how we might design this public health campaign. And so we worked with Tracy Epton, who's a psychologist based at Manchester, and she did a lot of qualitative work around this, understanding why people continue to use sunbeds. We probably all know that sunbeds aren't good for us, but there are some of us that still feel that there are some benefits from using sunbeds. And so we needed to understand that to try and think about what we'd need to do to design a public health campaign. And the obvious thing is to be clear about what sunbeds do to you, your skin and your eyes, but also say, look, there are other things you can do. There are other alternatives. And so maybe think about these other options available to you.
Yeah, personally a fan of Bondi Sands fake tan.
Hey.
You know, got to do it. Dove gradual tan, get in there. But yeah, I think there's a lot of dissemination of fake news actually around sunbeds, and people kind of. I've read online, you know, and I think it references it in the BBC article, actually, this girl called Sasha, where she went on sunbeds because she thought that they gave her a base tan. And this kind of vitamin D diatribe. Yeah, I think the kind of public health campaign side of things is so important to stop that dissemination of fake news, because, I mean, once it proliferates, it's there and it's there for good. And yeah.
Yeah, there is also a side of it, though, that, you know, people just like using sunbeds. It makes them feel good. They like that time, you know, lying down, making themselves brown. They like that. And so we did look at this in our mathematical model as well. And so we looked at, well, what would happen then if we sort of factored in this anxiety level from taking away sunbeds from people, which is potentially what it might cause. Even if we took account of that, on balance, it was still a good thing to do. And so, again, at the individual level, those people would need support. If you're taking away their sunbeds that they like using, you can't just leave them. You know, they've got to have some support. But I still think if you look at the numbers, it's a good thing. The other people involved in this, obviously, are the people who provide the sunbeds and their business. It's their business. And I understand that it'd be quite difficult to think about sort of repurposing some of those businesses, but it can happen. And with support, I think that is something that is possible. And I understand, again, people who make the sunbeds would be worried about this, but I think we have to think about the long-term health of our population.
Yeah, I also think it's great to see that it encapsulates this kind of wide landscape of sunbed use. You know, it's not just you looking at the public health side, it's looking at people's livelihoods that might kind of rely on this income and saying, well, actually, yes, we might have to take that away from you, but we're saving lives and money. And yeah, I think just on that, I'd like to talk more about this cost-saving element of the model. And, I mean, do you have any estimates of how much that would save the NHS?
Yeah, so the first thing to be clear about is when you build this model, you have to be clear about what viewpoint you're taking. So we did not take the viewpoint of a societal level. So that means we didn't include the impact on sunbed premises as part of our main analysis. So we very much focused on the NHS point of view. So if the NHS was prepared to invest in £1 million for a public health campaign, and that would be targeted at 18-year-olds. It would be a one-off, you know, let's target 18-year-olds, let's spend £1 million. And we think about having the population of 18-year-olds being of the order of 620,000 people, then that would save the NHS around £700,000. So you can tell it's about, you know, £1 per person if you want to look at it in that way. So that might not sound very much, but alongside that, you're also accruing these benefits in terms of avoiding cases of melanoma, fewer melanoma deaths, and improving the health of the population as well. So in some ways, it's a no-brainer. You're saving some money, albeit not a lot, but you're also accruing these benefits to the population. And I feel that's the important side of things.
And this is a term that I've kind of heard of. It's QALYs, which, if I'm right in understanding, quality adjusted life years. Mm-hmm. Was that put into your model?
So that's one of our things that we like to measure. So when we're thinking, remember at the beginning, we were talking about the scope of health economics. And one of the things I said, we've tried or done our best to understand this thing called health. What is health? And there's many different ways of measuring health. Health is a broad concept. But if we want to start to do these analyses where we say, right, what are the costs to the NHS and what's the impact on the health of the population, we need a ruler. We need something to measure it with. So that's what the quality adjusted life year is. It's our way of trying to measure this thing called health. So that means it's we have to go back to basics and think about, well, what is the QALY? So the first thing it is it captures the effect on the number of life years you have. So remembering opportunity cost as well. So we have to compare. So in this analysis for sunbeds, we compare people who've had access to sunbeds for their life and people who've not had access to sunbeds for their life. What's the difference in the number of life years? And that becomes subtraction life years gained. So how many extra years of life do you get? Now, some of those extra life years might not be perfect. So there are things that happen to people as they age, and if people need treatments and things like that, those additional years of life might not be at 100%. So you can quality adjust them. So that basically means downgrading your year at perfect health into a year at not so perfect health. And again, we need some way of measuring that. And so we have this thing called utility, where we place it on a scale to allow us to compare between different treatments. So our scale is anchored at 1 for perfect health. So if you're in perfect health, you get a score of 1. So if you have 1 extra year of life and it's at perfect health, that gives you 1 quality adjusted life year, because it's a perfect health for an extra year. If you are not so good and say your quality of life is less than 1, so let's say it's at 0.7, because we're on this scale from 0 to 1. So then you would say your QALY would be, for 1 year, would be 0.7 times 1 year. So 0.7 of a quality adjusted life year. So you see, if you start to then compare between treatments, you can work out how many extra life years you're gaining, but also what's the difference in these quality adjustments made to those extra life years. So you might be living longer, not at perfect health, but it's still better off than the alternative, which is being dead. Yeah. So so that's the basic idea behind this QALY. And then we have to have tools that we can actually measure the quality of life. So health economists have designed these health measurement tools. And the one that NICE says is perhaps the easiest one to use and the most common one to use is something called the EQ5D. And that is a very simple measure that has 5 questions, and you get people to complete those 5 questions, and then health economists work their mathematical magic and turn that into a utility value. So that's where the core basis for this quality adjusted life year comes from. Because if you give someone a new one of these targeted medicines, they might give you a few extra years of life, but they're highly unlikely to be at perfect health. Then you have to make this judgment, whether those extra years of life, how low does your quality of life have to be before it starts getting perhaps, I don't know, not a good thing to do, not.
And who makes those decisions?
Yeah, so the individual must make it for themselves with their doctor. So if they're in a position of having a diagnosis of cancer, they should have an individual level have a discussion with their doctor and maybe pharmacists and specialist nurses about the benefits and the risks of this particular treatment for them, and what they what the beliefs are about their life and things like that. So that is definitely down to the individual. But at a population level, you can say, well, if the NHS invests in this new medicine, this is how many extra years of life you're going to get, and this is how many extra quality adjusted years of life you're going to get. And then we need some criteria to say, well, then is it worth it? And this is where this thing called the threshold comes in, that you've probably come across as well. So NICE talks about this threshold of £20,000 for an extra quality adjusted life year. And what that is saying is that decision makers taking on the role of making these value judgments for how to spend the NHS budget is saying, on balance, we think if you're paying less than £20,000 to gain one additional quality adjusted life year, then on balance, that's a good thing to do. Now, other things come into that as well. So the quality of the evidence that is going into those decisions, the quality of the trial data, and also the level of uncertainty about those data. No data are perfect. And so when NICE are making these decisions about new medicines, they're looking at the mathematical numbers, but they're also thinking about and making judgments about the quality of the data and the uncertainty in the data as well.
It's a controversial question, and I think you've kind of answered it, but would it be valid to say that, I mean, one life year that is quality adjusted and it's kind of worth living for a person in this country would be £20,000? That's what the life year would be worth?
No.
Okay, go on.
No. So there is work that has been done in the transport environment, and that does look at the value of a statistical life.
Okay.
And what that does is saying, okay, how much are we willing to pay to avoid a death, effectively? And they generated some numbers in the context of making everybody wear seatbelts in their car and asking people at an individual level, which they then added up to make it a population level, how much they'd be willing to pay to avoid basically dying. And so that basically is turned into the value of a statistical life. That is not the same as the £20,000 per quality adjusted life year. The £20,000 per quality adjusted life year is something to help people put the numbers that get pulled out of a mathematical model into some context. So that threshold could be any number. It doesn't have to be £20,000. But on balance, what NICE did is look over their past decisions and their past experiences and said, right, this feels like it's a good number to use. And in some instances, they do change that threshold. So they introduced a few years ago now something called the end of life criteria. So that meant that if people were very poorly, had very relevant population, so a specific population size, and had fewer than 6 months to live, then they would invoke another threshold. That would be higher. So they'd be more likely to say yes. So that threshold was set at £50,000 per quality adjusted life year. But again, this is population level, saying within our population, is the NHS willing to pay this amount of money to gain this much extra health? That's a slightly different concept to the value of a statistical life, which is how much should we pay to save someone's life? It's slightly different.
Yeah, I can see the nuance there. So thank you for me and for the listeners, because, that's clarified a lot. And leading on from this, so you've explained about how you model a health intervention, such as the banning of sunbeds from England. And in this specific study, it's been shown that it's both life-saving and cost-saving. So my next question would be, how much are health economics, such as this, needed to make policy changes and NICE guideline changes?
It's a piece of information. It's another piece of the jigsaw, if you like. So if you're deciding, so keep going back to NICE, but it's such a it has such clear processes about how it uses evidence. So NICE has many different heads. Some might say it's a multi-headed monster, but let's talk about it in the positive way. So it has lots of different programs. And as part of that, it produces guidance, but also guidelines. So guidance might be about a very specific medicine or intervention, and guidelines tends to be about sort of pathways of care. And so looking at someone with a particular condition from diagnosis through to end of life care, for example, that might be more about guidelines. And so within that, they'll use evidence from epidemiological studies, clinical studies, both randomized trials, also observational trials as well, observational data. So economic evidence sort of feeds into that. And then all those data are put together into a report, which is then read, digested, and talked about by a committee. So that committee then makes deliberations about whether they trust the numbers, what the numbers might mean to the NHS, and also, more importantly, patients with the condition and clinicians who treat patients with the condition are also involved in those committee processes. So they can feed in at a committee level about how good or how relevant these data are, but also it can get sent out to the wider population, and then people can put their stakeholders can make comments about these documents at a wider level. So then, health economics is just one little bit of the jigsaw. I think the challenge is that quite often it's viewed as a black box, and it's perhaps not explained very well, and so it can feel a bit like cooking up the numbers almost. And so I think that's part of the reason why I agreed to do this chat, really, because I think the more health economists can get out there and try and explain the methods that we use. It's really hard because when you're talking about things in the abstract, without showing someone the actual model and taking them through it and saying, look, this is what we did here, this is what we meant here, it's really hard. But at a sort of a on average level, I think we should be better at explaining. It's not just about saving money, it's about using resources better. And so going back to opportunity cost, if we spend the money on this group of patients who have lung cancer, as distasteful as it sounds, that means people with mental health problems don't get the money from the NHS, because the NHS isn't a bottomless pit of money. So we have to move money around the system where we get the most value from it, value being benefit to patients. And so we as health economists can only provide that information. We don't make the decision. We give people information that's hopefully clear and transparent enough that they can understand what we did and why we did it and what it means. So
yeah, well, yeah, honestly, thank you, because I think in my job, I speak to cancer researchers kind of all day, and health economics comes up, and it's coming up more and more. And I think, as you've kind of described, it's what was the expression? A sword in the armory, metal in the armory. I don't know. I hope some of you know what that is. Something in the armory. We'll go with it. But it's kind of that case building exercise of, okay, you've shown that this drug is effective, or that this implementation is effective, but what next?
Yeah.
And you're backing people, and yeah, thank you for being so transparent and brilliant about talking about everything that you do, because I think it's just great for people to know. And I'm under the impression that in cancer research, health economics will become more and more prevalent in terms of people wanting to do things. They'll need support and that sort of thing. I want to make a kind of utopian Catherine world now.
Oh dear.
It's great. There's wine everywhere. It's maybe a bit cooler outside than it is today. But I mean, what is your hope for the use of sunbeds by 2030 in England in this utopia?
Okay. Well, at least at a minimum, know how many are out there. That's the first thing. And I don't like taking away things from people when they see value of them at an individual level, but personally I hope that we don't see them on the high street anymore. I think there are other things we can do to make ourselves either look better or feel better, and I think reliance on sunbeds is perhaps not the best thing. So I'd like to say goodbye to them, really. Put them into room 101. Room 101,
that's your room 101. I love it. Yeah, I mean, great answer. I can roll with that. I can definitely get on board. Like I've said before, there's tanning options out there, people. There really are. This is a question that really intrigues me, and I like it from the cancer research perspective as well. But the way that I personally think of people saving lives is the general nurse, doctor, clinician route. And it's like when you're a kid. who saves lives. Well, doctors save lives. But there's jobs out there, such as being a health economist, where you can benefit and save the lives of many patients and people, and even, prevent at the kind of root cause. And I'm wondering, how does it feel that knowing that you have this impact on the lives of the population?
Oh, interesting. Do I know that I have this impact? I don't, do I? Because all I do is I produce information for people. I can't make people read that information, and I can't make people act on that information. That's for somebody else to do with more power than I will ever have. But I hope, because I could do other jobs. I don't have to carry on working as a health economist. So there must be something that drives me somewhere to believe that at some point, people will listen, and also understand that we're not about being money pinchers. We're not about cutting costs. We're about trying to use what we've got in a better way. That's what we want to try and achieve. And so, my hope is that people do read the work of health economists and that they act on it. That's all I can hope for.
Yeah, there's a power in changing people's minds. A great power. Okay, and leading on, last but not least, a lovely question. What continues to inspire you?
I'm very good at deflecting away from myself here, and I'll do that. What inspires me is working with other health economists, and specifically people who are new to health economics, persuading people to get into health economics. So coming in from different backgrounds, and I supervise PhD students, and so turning them into people that hopefully will grow into grown-up researchers and have an impact themselves. So it's about the early career researchers, keeping them engaged in the topic, providing them with opportunities to use their own skills. I now work with people that are so technically clever. They can do such amazing things that my job is just to be a sort of a conduit to allow their brilliance to come through. So that's what keeps me going. It's these early career researchers. And, you spoke earlier about, for cancer research, needing more and more health economists. Well, health economists are a rarity as well. There's not many of us. And so at the minute, we have to decide where we spend our time. And so by trying to build this the future into, future health economists, hopefully some of them will spill over and start working in the area of cancer, early detection and prevention. And that's where they'll have their impact as well.
Well, any budding health economists, get over to cancer and early detection. We need you. Well, thanks so much for speaking with me. I know it's, one of those things that some people don't like, but honestly, I think the listeners would agree as much as I would. You've been brilliant. You've given a great insight into health economics. I've learned things, which is great because my brain is sometimes not so sponge-like. And as I said, I'll link everything we've discussed in the blurb, but that's it for now, and catch you all again next time.
Bye, everyone.
Bye. If you have been affected by anything you've heard in this episode, please see the show notes for a list of charities and organisations that can help.
1 in 2 was brought to you by the University of Manchester and the Manchester Cancer Research Centre. Listen to our next episode to hear from more of our researchers as they share the innovations, discoveries and projects that are changing the landscape of cancer prevention, early detection and treatment. To find out more about what you've heard today, please see the show notes for this episode, where you'll find a transcript and links to further information and research. Cancer is one of the university's 5 research beacons, showcasing the interdisciplinary collaborations and cross-sector partnerships that are tackling some of the biggest questions facing the planet. To hear more about Manchester's research in advanced materials, biotechnology, cancer, energy and global inequalities, go to manchester.ac.uk/beacons.